Good afternoon, everybody. So glad to see everyone here back in the spring quarter as we restart our colloquial series. Privileged to have Dr. Chethan Sarabu, one of our former clinical informatics fellows. Done very many exciting things back then, and apparently even bigger and better things since then that I have not heard about. Before we maybe dive in too deep, unless you're an acting talker, just tell us a little bit about yourself, Chethan. How did you arrive on this topic and your training and your life story a little bit?
Yeah, thank you. Thanks very much, Jonathan, Nikum, the whole BMI for the invitation to talk about informatics. And my first few slides were just on that topic as well. I'm going to
take it away.
Talk a little bit about what I do today and how I got here and how it ties into climate health informatics. So, Jonathan mentioned I was a clinical informatics fellow at Stanford a few years ago, graduated in 2018. And since that time, I've maintained this hybrid role where I work part of my time as a general pediatrician at Stanford at one of the community health clinics, as well as affiliate faculty member for the informatics department. I work with a fellowship. And I also have a role in the digital health industry at a startup called DocAI that then became acquired by Sharecare. And then I also work with the Stanford Natural Capital Project, doing research on the intersection of nature and health. And then just my disclosures, I am an employee equity holder of Sharecare and a sleuth, but none of what I'm going to talk to you about today has any relation to any of those items. But really getting back to your question of how I got here and how I'm going to talk to you, why I'm talking to you about climate health informatics, really stems back to my training in undergrad. I knew I wanted to go into medicine. I wanted to become a pediatrician because of experiences that I had as a pediatric patient. But I was also really interested in the broader conversation and context around health. And I was at Cornell in the Northeast, grew up pretty close to there. And I was a biology pre-med student, and I very serendipitously took a class in landscape architecture. Knew very little about it, knew it was about designing things outdoors. And it completely ended up transforming the way I thought about health. And I ended up double majoring actually in landscape architecture and biology. So landscape architecture is really about the environment, understanding environmental health, how we design environments that promote human health. And there are just many, many links between the natural environment that we all live in and human health. And that's really led me down this long path to where I'm actually now focusing on the intersection of environmental health and human health in this emerging field of climate health informatics. So after that early start and training, I went to medical school in Austin, upstate New York, trained as a pediatric resident on the East Coast, and came over to Stanford for a fellowship. And so with that, what I'm going to talk to you about all today is this topic of climate health informatics. I wanted to break that down for you. So climate, referring to climate change. And there's a lot that we could say about climate change. I'm going to just briefly touch upon that in this talk. This is not really going to be a talk about climate change. That is accepted science. And so we're really going to talk about that intersection of climate change and health, and then really that intersection between climate health and informatics. So to begin with, a really good place to start is the IPCC report. This is the report that you're all probably familiar with. It is that global consensus statement on what is going on, what the scientists around the world think in terms of global warming and how that impacts different systems. In addition to the IPCC report, there are other bodies that you might have heard of, the COP, or Conference of Parties, and this is the United Nations organized conference that's brought together different countries, leaders to talk about the impacts of climate change. And at all of these events at IPCC and COP, health has not really been a key focus. The very first time COP had a healthcare focus was in COP 26, which is the previous one in Scotland. And that was the first time where there was actually a specific track around the health impacts of climate change and what countries should be doing about that. And we know there are a lot of implications in many levels, but at the highest levels, a half a degree of global warming, of going from 1.5 degrees Celsius to 2 degrees Celsius warming, which we're trying to avoid, could mean 1.7 billion more people who are exposed to severe heat waves, 100 to 400 million more people who might starve from hunger, 1 to 2 billion people more who may not have access to adequate water because of all the climatic changes that might happen. And so there's a lot more to say about this, but I'm going to move on, but wanted to just make sure you're oriented to these resources. And we also know that there are huge inequities in how we talk about climate change. The richest 10% of countries have contributed massively with the burning of fossil fuels over the past few decades, but the impacts of that are felt among the most vulnerable. Even within our country, the impacts are very inequitably distributed. And so this is a global health issue. This is a health equity issue. And so there has been an increasing focus on the health aspects of climate change. The World Health Organization has an Alliance for Transformative Action on Climate and Health. And then there's an increasing focus from the US federal government that I'll talk about, but this was an editorial on the right-hand side from John Balbus, who's the first director of the Office of Climate Change and Health Equity, part of Department of Health and Human Services, and talking about some of what the momentum that's been building around health discussions at a global level. The equivalent of the IPCC report in the healthcare, in the climate and health space, is the Lancet Countdown. So the Lancet has been doing this series since 2016, an annual report summarizing all of the scientific findings on the health impacts of climate change. And so if you want to get deeper into that science behind what's going on between heat and other changes in our climate, the Lancet Countdown is a place to go for that. There's also the Medical Society Consortium on Climate and Health, which is a great organization that has brought together at least 40 different medical societies right now, including the AMA, the American Academy of Pediatrics, and many others, but about 40 medical societies that represent over 700,000 healthcare practitioners. And they have a great set of resources to really outlining the different climate changes impact on health. We are starting to see a greater number of publications in the literature. I mentioned the Lancet, the New England Journal of Medicine has this great interactive piece. If you look up the climate crisis, health and care delivery, where you can really drill down and look at different drivers of climate change and how they relate to different human health systems. And some of these changes are when I started looking into this work, some of it was obvious. We know that bad air pollution, which might happen from wildfires like we've been exposed to in Northern California and Southern California, can impact people with asthma and cause asthma exacerbations. There's also a lot of less obvious links that have been coming out too. There's now, from a systematic review, a significant number of literature too that's shown the association between air pollution and not great pregnancy outcomes, preterm births, low birth weight, stillbirth. And so we understand a lot of these pathways already, but there's still many more that are being uncovered. And there's also the impacts, again, speaking of the inequity of it, children, infants, fetuses are particularly vulnerable to a lot of these changes. As a pediatrician, this is where I focus a lot of my my energy around this work. But there are also with heat-related illness, children and infants, as well as individuals over 65 are most at risk. So with the health risks, those are also going to vary based on age, based on underlying condition. And these are just pointing out a few of the resources. There are many more and more being published. This particular paper looks at some of the direct health-related impacts of burning fossil fuels and the pollution that comes from that, as well as some of the mitigation efforts, such as planting trees and getting to eat cleaner vehicles and what that might have in terms of the health impact. And I'll point out a few of those examples throughout the talk.
Are there any analyses of how, say, global warming, increase in temperature would help improve health? And there will be certain regions that will benefit, right? So it can't be completely negative. Is any of these analyses looked into that, or is it all just doomsaying?
Well, I think when you look at the changing climate overall, yes, there are going to be parts of the world that actually may become more habitable. And actually, where I come from in upstate New York, near Syracuse, New York, is considered the best city to move to from a climate perspective. Duluth, Minnesota has actually launched a campaign to get people from Miami to move to Duluth.
Okay.
So there is that part of it, but there's going to be regions that were less less favorable. But the thing is, we have very interconnected global systems of health, of public health, and it's about, even though there may be regions that become more hospitable, it's about being prepared for that transition. And right now we have, if you just look at the United States, most of our population lives along coastal areas that are more at risk for floods. And so there may be parts of the country that could be better, but it's really about that transition and how we're going to get there equitably.
Okay, thank you.
Yep.
I'm hoping to take 20 seconds and editorialize a little bit, but there's compostable material everywhere and people are just push for electric vehicles. And then you look at the numbers and there's like low single-digit number of companies that do like the majority of like the dumping, Gazprom and like Saudi Aramco and things like that. So, I mean, I find it strange that, we're biking instead of driving, and then there's all this, there are all these other companies that are like doing millions more of like dumping, into the environment. So, yeah. So, commentary on that, like, wouldn't that be like one of the first places to kind of?
Yeah, I mean, this gets at the whole question of what can we do on a personal, individual responsibility basis versus what is the action that's needed to be taken by the few that have maybe contributed the most. And that's a debate that goes on, and there's maybe a whole discussion around where can we be most effective. And that's what some of the organizations like the Medical Consortium, they have been focusing on that piece of where are the greatest levers to put action to make the greatest change. So that's what I'll say for now. I think with this particular focus, wanted to give more of a broader overview of where the opportunities exist. But yeah, it's a great question on what is that balance between personal responsibility, how much does that really change versus getting broader political action for greater systemic change. And so from this introductory section is really about the advancement, high-level overview about the advancements between the links between changing Earth systems, the mechanisms that relate from there to different disease. So we're starting to better understand and map these out. That's what's happening from advancing the science perspective between climate change and human health. There's also a lot happening at this intersection of climate change and health systems. We are seeing in California with the heat waves, with power cuts, a number of changes that are being driven by increasingly warming planet, that our current systems of electricity supply are a lot more vulnerable than we might think. This was a great article on a health system near Sacramento, having to decide during some of the planned blockages by PG&E whether to keep their EMR running for a few days or whether to make sure there was enough power for the fridges with vaccines and other perishable medications. And so there's a whole body of work. The Commonwealth Fund on the diagram on the left has a great report and article on what health systems are facing as a result of climate change. And there are a lot of really big events that that made national news over the past few decades. Of course, Hurricane Katrina in New Orleans and what that did to the entire city and particularly to the healthcare system there. As well as in New York with Superstorm Sandy almost a decade ago. And really that led this lesson of most hospital generators were in the basements, which is a really terrible idea when it came to flooding. So there's a lot that health systems are learning from a resilience perspective from climate change. Beyond the healthcare system, it's individual hospital systems. There's this whole new question of coordination across the region. So back in 2021, there was a huge heat wave in the Pacific Northwest, a heat dome event And the Pacific Northwest, Seattle is an area that has a very low percentage of people with air conditioners, second only to San Francisco. San Francisco is the city in America where the least percentage of people have air conditioners. But in Seattle, with these heat waves that were coming, there are a lot of very vulnerable people, people over 65, people under 1, who are particularly vulnerable to heat stress. And so when this heat wave came in, you had an excess number of people with heat stroke who didn't really have the appropriate cooling resources, didn't know what precautionary measures to take. And there was a huge spike in emergency department visits. A number of stories had come out at the time around overcrowding, patients coming in for an MI or a stroke weren't able to be seen in a timely manner because of the huge crowding from the heat strokes. And so cities around the country are starting to think of how do we better connect the dots, connect the resources. Cities like Miami just appointed their first chief heat officer to think about this, not just from a healthcare system perspective, but a broader kind of city and regional perspective. And so you can imagine from an informatics perspective, from an interoperability perspective, there's a lot that we could be thinking about here in terms of the coordination of resources and people moving across a particular geographic region when there is an event like this. And we also know that there are concerns around how with increased heat, there are a lot of issues where there's disproportionate effects. We know from a history of redlining that led to neighborhoods. Someone's trying to ask a question or?
Just keep going.
Okay. From the racist practice of redlining, we know there's neighborhoods that were less invested in, particularly those of Black Americans. And so those are neighborhoods that have had less trees invested in them. And there are a number of studies which shows the deleterious health effects of that over time. And one of those is the lack of being able to mitigate the urban heat island effect. Trees provide many different health benefits, and one of those is to decrease that heat that's felt at the human level. And so there are a number of these health system related risks. And so this is actually from a report by Deloitte, and I'll share the full more details from the report in the following section. But they've been starting to document how these rising temperatures and the related impacts multiply the different risks to human health, multiply all of the concerns that we have around SDOH, around social determinants of health, and how these lead to things like increased hospital admissions, supply chain disruptions, a lot of the things that we learned during COVID, but are going to continue to get amplified. And then we're starting to also measure the financial costs of these two healthcare systems. This is all part of the same Deloitte report, but Brigham and Women's in 2015 from an extreme freeze led to cancellation of elective procedures that led to a loss of $10 million, I think, over a very short time span. Superstorm Sandy in New York led to a shutting down of 6 hospitals, 26 residential care facilities. And even a month after the storm, the health system's bed capacity was down by 5%. And then the deep freeze that happened in Texas had a number of implications for many different health systems there.
And there's also sort of more recent events that not just the heat side of things, but the water pouring down on California side of things, where cities like Menlo and Palo Alto are now questioning their tree ordinances, and should we have heritage oaks that can then just topple over and kill you and crush your house. Like amazing reversal of fortune and thinking in a matter of 24 months, where you would be fined for even cutting a sapling, and now people want to get rid of these big trees.
No, it's really kind of raising a lot of new questions, a lot of new trade-off calculations are being created. There's a lot going on in the kind of insurance market for property too, and really reevaluating where things should be included or not. And many parts of the country that are particularly at risk for flooding, oftentimes the pure market insurance play doesn't fully work out, but they do, it's subsidized by the federal government. There was a recent report by the federal government that said, should they be subsidizing insurance in flood risk zones or change those maps? And so there's that whole conversation that's going on too, that's kind of underlying. great example. This was also cited in that same Deloitte report, but comes from an NRDC estimate of the currently estimated healthcare costs related primarily specifically to air pollution driven by climate change is estimated to be around $800 billion. And that a huge portion of that comes related to premature deaths.
Is that internationally or is that US?
That's a good question. I believe this is US,
Yeah,
but
feels like,
yeah.
yeah.
Did they separate out the two sources? Because those are two different costs.
This particular, they had both mentioned together. I didn't look into their
Okay.
sub-analyses, but it's a good point, yeah. So I hope I helped to set the stage around what we know about climate change and health and the relationship, and then climate change and health systems. So what is going on? What are the actions that are being taken from different sides, from a regulatory top-down perspective, from a bottom-up advocacy perspective, and what are those emergent market forces and opportunities that seem to be arising? And then once I set the stage with this, I'm gonna then move to focusing on where informatics comes in. So from a bottom-up advocacy perspective, there's a lot happening. There are a number of different healthcare organizations, many cited here, that have been growing, really focused on a lot of the healthcare providers and people around this network who are really activists and care about this and have been called to this work for one reason or the other. And then there is work going on at Stanford. So there's Stanford Climate and Health, which is organized largely by a group of medical students, but there's a good number of a wide range of folks from a lot of faculty on the medical school side to all the way to undergraduate students and even high school students. And so if you're particularly interested in joining this, if you look up Stanford Climate and Health, there's a way to get enrolled with what's going on campus, to join some of the listservs and find out what's happening in the space. A lot of the advocacy and activism is really coming from youth. For younger people, this is much more of an existential threat compared to those of us who are older, in terms of what the planet might look like in 10, 20, 30, 50 years time. And so there's a lot of activism from younger individuals like the Sunrise Movement, and then there's also the Climate Mental Health Network, which has been really looking at a lot of the mental health impacts of really having this existential threat weigh over you as a young person. And something that I've seen a little bit in my pediatric clinic, not super prominently, it's not a standard part of what we talk about right now, but that is changing based on particularly where you live and some of the impacts that you've experienced. There's also a lot of activism from indigenous communities, indigenous communities have really been talking about needing to live within the environment, within the capacity of the earth without disrupting this balance. And so indigenous communities are really great conservationists, and a lot of the protected biodiversity really comes from places that have a larger indigenous population. And this book, Sustaining Life, is a really good book by two physicians at Harvard that really talks about how a lot of the advances in modern medicine have been made as a result of preserving biodiversity. The frog on the cover was one that was being studied as a treatment for gastric ulcers. It's a frog that has the mother actually lays the eggs and then I think swallows them inside the stomach, and the baby frogs actually grow up within the stomach, and the frog is able to downregulate acid production. And so it's being studied as a means of finding new drugs for gastric ulcers, but then as a result of the loss of biodiversity, the frog became extinct. So really interesting book about why biodiversity matters.
You don't have to eat the frog.
No.
That's good.
So that's the bottom up advocacy that's happening, but what about what's happening from top down? So from the Paris Climate Agreement, which you might be familiar with, there was this global agreement around trying to not go past 2 degrees Celsius globally. And that really was sort of the best agreed upon measure, but really trying to keep it to less than 1.5 degrees.
Sorry to interrupt. Is it really true that Greenland was not a signatory? That's hilarious.
It's possible, yeah. I don't know if it was error data
So
not
ironic.
available or.
Yeah, maybe you can have it, though.
You're right.
Well, but Denmark was.
All the ice melts.
And then we famously were a signatory and then left and came back too. But I think one thing, thinking about when we say like a 1.5 degree rise in temperature, 2 degrees rise in Celsius, I think it doesn't seem like a lot when you hear about it that way, but thinking about the human body, we understand in this clinical context that living organisms really have this equilibrium that's established, that's a really fine balance. And so when our body goes from our normal temperature to a fever, even a slight fever, that starts to throw a lot of our normal systems off. And so it's really about thinking about the planet as this interconnected organism of ecosystems and how that rise in temperature really disrupts a lot of established systems. Continuing on this top-down approach, the US government through the Department of Health and Human Services has set up an Office of Climate Change and Health Equity a few years ago at the start of the Biden administration, and they released this Climate Change and Health Initiative Strategic Framework with the NIH. They're really pushing to coordinate across the federal government many different initiatives for climate change and health. This is currently an unfunded office, so it's still pretty minimal in terms of what they're able to do, but it shows that there is this direction that's coming from top down. But then a lot of the large medical societies and organizations have also jumped into the space. AHRQ, the National Academy of Medicine, IHI, the Institute for Healthcare Improvement, have all been focused on decarbonization of the US healthcare sector. So this graphic in the middle shows that the US healthcare system in our country accounts for 10% of our national greenhouse gas emissions. And if that was a country on its own, that would be it'd be the 13th most polluting country. Our healthcare system's greenhouse gas emissions are more than the entire emissions of either Saudi Arabia or the United Kingdom. And most countries' healthcare systems are typically around 5% of their national greenhouse gas emissions. And so we're about double. There's a couple of different analyses that look at this. Some of them peg it around like 8%, 9%. Some go a little bit higher, but you might see anywhere from 8 to 10% quoted. And this is really where a lot of these organizations, including the IHI, have focused on getting healthcare systems to focus on reducing their carbon emissions. And Stanford Healthcare is actually part of the IHI Decarbonizing Care Learning Community and part of the federal government pledge as well. That I'll mention in a second. So in addition to these organizations, another big top-down investment that's happened is the Inflation Reduction Act. This was the single largest investment in climate in history in the US or globally. It was $400 billion of an investment in climate change. And it's complicated to understand and unravel because it works through a series of different tax credits and incentives, but it's trying to do a couple of different things that have interesting connections to healthcare. So it is trying to promote increased transition to electric vehicles. And there's a couple of interesting studies that have come out in that space. This one cited on the right was a study that looked at different California zip codes, percentage of EV ownership, and then looked at the amount of particulate matter, specifically nitrous oxide, and then they looked at the number of ED visits for asthma and other for asthma. And they found that in those zip codes where there was a higher percentage of EVs, they did see a statistically significant drop in ED visits in those communities. I didn't go into the full paper in terms of how they controlled for everything, but this was the first study of its kind, at least that I've come across, that's starting to look at how as you have more EVs distributed throughout communities and you have less pollution at street level, what might that do for communities in terms of their respiratory triggers? There's a lot of focus on electrifying school buses, and that also has come from the Inflation Reduction Act, particularly for children, where they are spending a lot of time around buses. And then on the left, and these are screenshots from this recent medical consortium conference. The IRA has incentives for healthcare systems, particularly community health centers, which are often in more impoverished neighborhoods, to actually invest in creating resilience hubs. So during the time of a natural disaster where patients might be unsure of where they would go, or particularly if they're dependent on electricity to stay alive, there are dollars from this that can help community health centers actually become those resilient climate hubs. And then in terms of market forces that might push for more change in the climate and health space, there's starting to be the emergence of a few different factors. So healthcare systems, particularly in the Bay Area and the Boston area, are starting to brand and advertise themselves as being more green and sustainable. Kaiser in 2020 announced that they were the first carbon neutral health system. Stanford, along with 40 other institutions last year, signed the federal government's climate pledge that by 2030, we're going to reduce our climate warming emissions by 50% and achieve net zero emissions by 2050. John Doerr and Kleiner Perkins, and the funder of the New Doerr School of Sustainability, has in his list of key measures to focus on, in the top 10 list, has addressing air pollution globally as one of the key measures. And so there's been an interesting focus on that, particularly from a little bit more that community in focus. I mentioned this Deloitte report. Deloitte has been looking at the industry side of things, and they authored this report recently, Why Climate Resilience is a Key to Building the Healthcare Organization of the Future. And they break it down into different aspects of mitigation and adaptation, mitigation being decreasing the healthcare system's role in advancing climate change, and adaptation, how do healthcare systems and communities adapt to the challenges that are ahead. And so this has a number of ideas that potentially point towards signs of investment opportunity in the market, but a lot of these are still really nascent in terms of a true market opportunity. We're also seeing other players in the healthcare ecosystem get into the climate and health work. Med device companies. This article on the left by Stat was actually by Philips, and was talking about what medical device companies could be doing in terms of their materials use, their supply chain. A lot of pharmaceutical companies like Roche have been really talking about how they can decrease the amount of material they use in the manufacturing process of drugs, as well as getting to reducing the amount of energy they're actually using. A bit more informatics related, thinking about the cloud storage systems that we're using for storing data, for running models. Many of the cloud storage companies are starting to tout their green benefits and starting to really measure, make investments in energy efficiency, cloud compute. Epic, the EHR company, they're actually one of the largest geothermal plants in North America for their cooling. And so Epic has like a green sustainability task force, and they were talking about the investments that they're making in terms of the energy use of the EHR, particularly for customers where they're storing their data on the Epic cloud. And this is a transition now to really getting to the informatics part of climate health informatics. But I know that was a lot of background context, but wanted to give you that broader perspective on what's happening between climate change and health, climate change and health systems, and what actions are being taken both in a top-down and bottom-up approach. So EMEA, through JAMIA, the Journal of EMEA, had a special issue on climate change and biomedical informatics last year. And this was their overall editorial piece that talked about it was really a call to arms for health informaticians around what you could do as an individual, what type of things you should start to think about within the context of your work with this work around climate change. And so I had and kind of further breaking this down, there are a number of aspects of informatics and the work we do across biomedical informatics and clinical informatics and public health informatics that start to fit in. We are able to help break down complex problems into measurable and manageable chunks and pieces, help to operationalize data standards as we try to reduce carbon emissions from healthcare systems. There's a lot of questions around how we're actually measuring this in a standardized way. We do things like clinical decision support that are behavioral nudges that might be able to nudge in more sustainable care. And so there are a number of aspects of those are just a few of where informatics can really make a difference in this work around climate change. And then this was a survey that I led with a few others based here at UCSF, at the Boston Public Health Commission. We did this pilot survey of health informaticians from around the country, had about 85 respondents split mostly on the West Coast and East Coast, with some in the North and Midwest and Southeast, where we asked about different perspectives around climate change and health and where everyone was with it. And so we started off with asking how significantly do you think climate change is impacting health? And the majority of people felt that it was extremely or very, but there were people who also said they don't think it was and that there's still more to be discovered there. And then the last question here, I think the text is not super clear, but should existing healthcare organizations, EHR systems, incorporate information about climate-driven environmental information, and about 70% of people said it should, respondents. But we had a pretty wide range of responses, but we asked about natural disasters, about different informatics tools that are already implemented or likely to be implemented. And then we also asked about education in a sector. But the key takeaway is the informatics community, at least from that we got in our survey, which I think was fairly representational, did feel that there is a role for informaticians to play in this. And what we hope to do is really expand this pilot survey and help reach a broader audience later this year. So there was the beginning of a framework that we established with this paper based on the feedback that we've gotten from our surveys. There were other publications too that came out in the same issue that are really trying to establish frameworks of how to think about climate change from a clinical informatics and biomedical informatics perspective. And so there's the iClimate framework, which is the work led by Dean Sittig from the University of Texas, and then this Green Mission framework, which comes out of a team in the Netherlands. But these two frameworks are really about helping health systems think more about the different energy use and climate implications of a lot of the tools and services that power a lot of what we do. But to take this further, I am helping to lead and run a workshop at the EMEA CIC conference this May, if any of you are going to be there. Climate health informatics, a design workshop to accelerate action. We brought a lot of these different folks together to build more of a consensus around a framework. And really to illustrate this a little bit better, this diagram shows you have a warming planet that has direct and indirect effects on people's health. There's direct impacts on health systems and being able to respond to natural disasters. There are impacts on communities. There's the health impacts of heat waves, but there's also the health impacts of disrupted healthcare services. And so if we start to think about where different informatics tools layer in and fall in, you could see from a data perspective, we have environmental data around the planet changing. We have health system data on where different people's health risks are. We have population health data, and these are often siloed and not really connected. There's obviously different interoperability efforts that are going on to connect the dots here for a variety of purposes, but there's, I think, a great opportunity to really think more holistically about how these different sources of and silos of data start to work together better to be able to inform decision making in this space. And so there is this whole world of environmental health. There's this world of sustainability. There's this world of public health and emergency preparedness around climate change. And so I really see this emergence of climate health informatics as really being at the nexus of all of these different efforts that are already happening. But we need to better interconnect and communicate across these different silos. And I think a few of the specific projects that are going on that I'm going to be talking about are around clinical decision support tools and the sustainability efforts and some predictive modeling work that's happening in this environmental data to public health space. And so this is really this initial framework diagram of where climate health informatics might sit across all of these different areas. But we hope at this workshop at the CIC conference to really gain some consensus around this and take it to the next level.
Like, what do you think are the biggest sort of unanswered questions or problems that this framework is really going to move the needle on?
That's a good question. I think right now there is across these different areas of work, from emergency preparedness to some of the environmental public health work, there's a lot that's happening in silos. So and I'll talk about one of the examples. So at the city level, there are cities working with public health agencies to try to map out heat hotspots to see how they can help people with increasing heat. And then that's also happening at the healthcare system level, but those efforts are not really interconnected to each other. So there might be a community that says, this is where we need to invest in cooling centers. And then there might be work at a hospital that is preparing their emergency department for a heat wave. But those modeling efforts and that coordination is still happening in isolation, at least from what I'm able to gather. And so in that one example, if we're able to have a common framework and a common language, my hypothesis that we'll be able to better align these efforts and coordinate resources and efforts across these silos.
I think the best thing you can do for informatics people is to define a set of well-defined problems in terms of inputs and outputs, right? You can use any technique they want to solve them, but you know, what are the inputs, what are the outputs, and within this, and if they hook together, even better, but they don't have to. But I mean, most people don't want to work on do the big picture. They want to work on small, well-defined problems. I mean, we at least academics.
Yeah.
Do you have a candidate? You mentioned a few, but you didn't go very far. You're going to do more?
Gonna do more. Yeah.
Oh, well, okay.
But
Sorry, I'm gonna miss it.
That is a good point. So one of in terms of those specific project areas, so the first one I'm going to talk about is health system sustainability. And this is where there's a lot of momentum, particularly at Stanford, because of that climate pledge that we've signed and the work that we're doing with the IHI. And just before I get into that, I also had one slide too about this growing body of work around the considerations and implications of AI models, of large language models, and other AI systems in terms of their carbon and greenhouse gas implications. And so this was an interesting review from. It was not in a peer-reviewed journal, but it was picked up by the MI Technology Review from medRxiv or bioRxiv. And they looked at the Hugging Face model, which was estimated to generate about 50 metric tons of CO2 from the training, which is equivalent to about 60 flights between New York and London. Yeah, but they actually think this is much more energy efficient compared to some of the other models because it was mostly trained in a French supercomputer in France. Famously, is actually largely nuclear powered. Compared to most other countries, whereas so GPT-3 is estimated to have been trained, just the training itself is about 50 metric tons of CO2, so about 600 flights between New York and London just from the training. But then in this paper highlighted before, they talk about there's a lot of choices that could be made that in terms of the training and the compute and the data centers that are used that can actually make huge differences in the carbon footprint there. And then there's this good paper from Nature Climate Change on how to best align artificial intelligence work with climate change mitigation, and it goes into a lot of these in-depth into a lot of these considerations, which I'm not going to talk about today, but just wanted to point that out. And the OECD has also been developing this global framework of how to think about the carbon footprint impact of AI. But more specifically in terms of healthcare systems and the greenhouse gas reduction, to the point of having some specific projects. So there are efforts underway to try to figure out how we reduce our scope 1, 2, and 3 emissions. So scope 1 and 2 emissions are generally less than 15% of a healthcare organization's emissions. Scope 1 is those direct emissions from a healthcare facilities. If we generate our own power, if we burn our own fossil fuels, it's those direct emissions that come from that. Scope 2 is the purchasing of energy. So if Stanford decides to purchase more renewable energy, that will basically help us reduce our scope 2 emissions. But still, the largest chunk, about 85%, is scope 3. And that's all the stuff we do. It's all the supply chain, it's the material, it's the transport of patients and physicians and staff. And so that's really where the largest opportunity is. It's also a lot more heterogeneous, harder to define and quantify and create standards around, but that's where there have been some efforts.
So on the previous slide, there's some interesting trade-offs. So in scope 2, for example, like Stanford made the change to go to fully sustainable energy, given our new energy facility, the SESI facility. But as a result, we have this weird constraint that our cooling is contingent on chilled water supply. And in the past couple of power emergencies, we were like 2-3 hours away from having to turn patients away because we wouldn't be able to cool the building. And there's nothing you can do to just manufacture chilled water out of thin air.
Yeah.
And our entire cooling infrastructure is dependent on that.
Wow.
So now we have this Achilles heel that we didn't have before. That if we run out of chilled water, we either start taking other buildings down and send people home, or start shutting floors of the hospital.
Yeah, that's a pretty stark example, but I think it also points to the fact that we need more interdisciplinary collaboration, because oftentimes the decisions to change where we're getting power from are often made from parts of the organization that are maybe more focused on the energy use and are not really thinking directly about the clinical care aspects. And so I think that's where, with this work, it's so interconnected and have all these unexpected trade-offs and risks. And so I think we need more clinical and informatics folks involved in these discussions and decisions that are being made to better understand the trade-offs.
5 minutes to the end of the hour, so if you want to.
Oh, okay.
Closing it.
Yeah, sorry, I will try to move, just kind of fly through a few examples. So there's a lot of efforts on reducing greenhouse gas emissions from surgery, really where there's a lot of look at single-use material, trying to reuse material, as well as decrease anesthetic gases that, like desflurane, that are particularly strong greenhouse gases. There's efforts around looking at the greenhouse gas savings from telehealth visits because people don't drive to work. And there are efforts around using different types of inhalers, dry powder inhalers instead of metered dose inhalers, because they have a lot smaller carbon footprint. And so this is actually the subject of a grant that I have along with Ron and Shay and a few others, where we're looking at these different clinically sustainable care pathways and exploring how we might consider integrating them into the EHR or CDS, and if that makes sense, and who they should go to. Another set of work is around predictive modeling, around risk of different environmental disasters, and how we might create personalized digital health tools to alert people in times of impending risk. And so there's a lot of data that's being made available from the federal government and from state governments. California has this, there's resilience.climate.gov that's making this data a lot more open source and available. California has a system too that they built on top of that called Calibrace. There are different initiatives, like this is a project from a clinical informatics fellow at UCSF looking at personalized healthcare risk and weather connections. And there's a few companies in this space as well, like WeatherWell and Prepared Health, that are trying to help create personalized preventive digital health tools that look at changes in pollution and weather and alert people with respiratory disease, for example. From a community and health system resilience perspective, this is work from a collaborator in Arizona, the public health system, that's been working to map out heat hotspots and to better identify coolant locations for cooling centers. There's this organization, Crisis Ready, that's mostly out of Harvard, that has been working to model these different natural disaster risks and healthcare facilities. And they've this diagram at the bottom shows the risk of fire threat zone in California and the percentage of hospital beds that are in those zones. And then finally, the last example that I'll mention, there's work that some have started around being able to better connect environmental impacts and factors at a broad level to what's going on at the individual care level. And this might actually be a coding/NLP project that's going on where there's a number of climate scientists who want to better understand when there was a heat wave, what exactly happened to those patients who came in with heat stroke to the emergency department, and can we do a better job of actually being able to use whether it's ICD coding or one coding or others to be able to better connect the dots between a climate driver and a health effect. And so with that, I will just end and say, and with this quote that I liked, of really, there's a lot happening with climate change and health. There's a lot of despair and doom, but I think there's also a lot of optimism and action. And I think informatics, the field, the community actually has a lot to offer for this work. And so hopefully that has been informative, and thank you very much for all of your time and attention. Yes.
We probably squeeze in one or two questions in the minute we have left. First, where do you think it's going? I mean, you kind of gave like a 50-minute background review, which is cool, but I'm totally not clear where this is going or what you want us to do, what your call to action is.
Yeah, it's a good question. I think, I didn't spend as much time on the end here, but I think with these different projects that are going on, the call to action is really one, to bring this to your awareness and consciousness that this is happening. And I think two, to really think about how we can apply many of the principles of being able to drive change at the systems level, whether it is helping healthcare systems reduce their carbon footprint and thinking about how we measure that and drive action around that, to how we better help advance the science around the links between different climate drivers and health. I think we're still in this early stage of figuring out exactly which action is going to be the most effective. But for us to get there, we need to be able to measure. And I think that's really where informatics comes in. It's this connecting the dots, it's being able to measure and being able to nudge change. And so that, I would say, is the call to action.
Can you go back to the slide where you showed the scope 1, 2, 3?
Oh, yeah.
So I am only recently getting exposed to more material about this issue, but I think it's this that really highlights actually the challenge of addressing climate change from a health system perspective, right?
Mm-hmm.
If Stanford Hospital scope 1 and scope 2 are basically a drop in the relative bucket of the things that are affecting climate change, then it's the decisions that affect scope 3 that will matter the most, which I read as needing to involve hospital operations folks at the decision-making level, right?
Yes.
And so your survey, are you going to, try to reach those communities? Is that the next step? How do you incentivize the decision makers at health systems to take action to move the needle on these scope 3 topics?
Yeah, it's a good question. Yeah, I mean, in our survey, we did have a lot of like CMIOs. So there's some operational efforts there. With the IHI collaborative as well as the NAM decarbonization work, there is already specific engagement on 3 key areas that Stanford has decided to engage with as well as 11 other institutions. And so one of those is actually around moving to more reusable surgical equipment. That is one of the biggest drivers of reducing greenhouse gas emissions. And to another big bucket of work is around anesthetic gases and getting desflurane to be phased out, switch to just sevoflurane. There's a lot of cultural change around that, but that's largely being accepted by anesthesiologists overall. I think a thornier problem is around meter dose inhalers. So there's some estimates that show 3% of a hospital's entire greenhouse gas footprint is all of the MDI prescriptions. And so there are these efforts to say patients should be prescribed dry powdered inhalers instead of meter dose inhalers. I remember bringing this up in a discussion in our Department of General Pediatrics, and there was a lot of frustration with that because culturally, in terms of practice, we use MDIs way more than DPIs. But then this brings up many of these interconnected operational issues. There is what is the accepted practice of clinicians. There is how do we actually measure this change? What do patients think? There's also, as part of a discussion with some payers, right now, a lot of payers through PBMs and formularies don't really list DPIs as much as MDIs. And so it's part of a conversation where a large payer was exploring how do we change some of the formularies to help in this regard. And speaking of payers, there's also the incentive that payers have to try to invest in more upstream prevention, particularly with these risk models. I think it's another key area for informatics work and being able to say, you know, if we know there's going to be a wildfire in a particular area and that people with asthma are more likely to end up with a flare, end up going to the hospital or ER admission or hospital admission, how do we actually incentivize and use that environmental health data and those personalized digital health tools, whether through something like MyChart, the patient portal, or through apps to actually to prevent that, to take more upstream care. And payers are starting to talk about that because they have the financial incentives to want to invest in that.
Fantastic. We're past there, so thanks so much, everybody, and hopefully we can see you around and continue the conversation individually with Chethan if you're up for approaching. Then come back next week. We'll be talking more about language models, foundation models, and healthcare settings, and get the right. Thanks, everybody.